Are we going to listen on skin or on top of the clothes?
Skin.
Skin. Now, that's one thing I didn't ask Dr. Harpole. I'm going to expect you to either say it. I'm going to be checking off too. If you're on top of clothes listening, I'm expecting before you place that stethoscope to say, I will be listening to on the skin, not on top of the clothes. If you don't say that, then I'm expect you're going to go to a patient and listen on top of their clothes, and that's not correct. Okay? Everybody, we're real clear on that, right? And I'm going to talk to her, and normally we try to grade across the board the same, because it's not fair, you know, to grade differently. So we really need to hear on the skin, okay? That's where you'll be listening. So whenever you, of course, start your check off, you're doing those introductions, that checking the record, the orders, allergies, reviewing vital signs, we're performing hand hygiene, for introducing ourselves, and identifying that patient by their armband, telling them who we are and explaining to them we're about to do a physical assessment, okay? Same as always, that first little blurb that's at the beginning, okay? So to start out with, we're going to start out with, this is, you know, the reason why it's called a head to toe is you try to keep it in a systematic way. The more you jump from the heart to the stomach, to the skin, back to the heart, back to the lungs, it's messy. It looks messy, and I'm not trying to be mean, it looks messy, okay? You need to keep it systematic, head to toe, best you can, okay? Because when you're assessing the skin, you're assessing the whole body, but then we're going to regroup and get back to that next step, okay? You need to get closer. Okay. So start out again, head to toe, we're going to start with that level of consciousness. Is that patient awake, alert, and oriented? Okay, awake is awake or sleeping, alert, they're conversing with me or they're looking around, and then oriented. There's oriented though to person, place, and time. So then we're going to ask them, hi, I'm Andrea. Can you tell me who you are?
Lauren Fulton.
Okay. Do you know where you're at today?
PMCC.
Okay. And do you know what date it is? In the morning or the afternoon?
It's the morning, Wednesday, September 14th, 13th.
13th. And then if you get the neuro assessment, I suggest go ahead and add in situation in. Person, place, and time, and situation. That covers you on orientation within the neurological assessment. You do it the same way every time. Try to do it, you're going to learn. The more you do it the same way every time, the better you're going to get at it, okay? Situation. Do you know why you're here today?
For a head-to-toe physical assessment.
Okay? That covers you. Your level of consciousness done. Okay? You add that situation in there. And then we're going to ask, are you in any pain today? Okay? Let's say she said she was in pain. Okay? Her pain level is a 4. We will ask her 0 to 10. Can you describe that pain for me? Is it throbbing, sharp, deep? Okay, a dull pain. Okay? And then we're going to go on into listening to the lung sounds, okay? Lung sounds are, there's a wide area to listen to for lung sounds. We're going to verbalize. I'm going to be listening. I'm going to be listening over the skin, not the clothes. You start, can everybody see okay? We're going to start just above the clavicle. Not used to doing that, are you? We're going to start, if you look on ATI, that's where the numbers are at. It starts just above the clavicle because that lung area comes really high, higher than we would expect, okay? So we're here. What am I going to say out loud other than that I'm listening on skin? What else am I going to say? Say it again. Take a deep breath. Each time I listen, I'm going to be listening to your lung sounds. I want you to take a big, deep breath in. Every time you feel my stethoscope placed on your chest, okay? All right. So then, am I going to just go anywhere else? Where's my next place to go? Straight down. We're doing a ladder, okay? Systematic ladder. And then over here, we're going to wait for that breath sound to go in and out. Then we're going to come here because of breast tissue on females, males too. You can go kind of more center, or you can go a little bit further over. If they're heavy muscled, you're not going to hear the lung sounds very well, okay? and then we're going to come here, and we'll tell them in real life, I would help move her breast out of the way, you know, and then go straight to that skin to listen. All right, how many points am I listening to? Ma'am? Okay. On ATI, it's got 12, just so y'all know that. 8 would be sufficient for me. And you can say on ATI, you're welcome to say it. There's 12 points. I'm going to list, or 6 together, 12 side to side bilaterally, and then we're listening, you know, right over here, okay? On the skin. Deep breath in and out. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, you can say I would listen up to 12 times over the chest. I don't think anybody's going to expect you to do all 12 while we're checking off, okay? So we're doing just anterior lung sounds for that head to toe, okay? So we're listening for, what are we going to say out loud that we're listening for? Breath sounds and any kind of adventitious breath sounds. You got to tell us that. Tell us. I'm listening for adventitious wheezing and crackling bronchi. I'm listening for that. We're going to then listen for PMI. Listen for the PMI, point of maximum impulse. All right, does everybody know where that's at? Fifth intercostal, if you're asked, fifth intercostal space, mid-clavicular line. This is our clavicle, clavicular, clavicle. Clavicle goes from here to here. What's the center of it? Straight down. Fifth intercostal space, mid-clavicular line. So on a female, normally, we're going to have, and you can have your fellow student raise up some, or you can say, and that's fine, raise up some, and then that would be roughly about right here on her, okay? And that's where I would listen. How long do we normally listen, especially if they've got an irregular heartbeat? 60 seconds or a minute, okay? No problems. Normally you're listening for 20, 30 seconds, you know, but just depending on the situation there. So that's our PMI. We're going to verbalize. I'm going to inspect the skin for color, any kind of lesions. On the rest of this checkoff at the end, it talks about assessing the anterior and posterior side. So we just say that because we don't expect necessarily for you to make them get up out of bed and I'm going to look at their back, you know, say it. I'm going to be looking for anterior and posterior side. That gets you that check off, that check mark done, okay? But we're assessing the skin for color, lesions, erythema. We're saying this out loud. I need to know what you're looking for. I need to know that you know what you're looking for. Colors, lesions, jaundice, cyanosis, pallor. I'm looking for all these things. If you don't know what those words mean, definitely look them up, okay? Pallor is like a lightness or a discoloration, like a whiteness of the skin where there's not good blood flow. Erythema, redness. You can just say these out loud, but that's what you're looking for, okay? Where's the best place to look at the true color of a patient's skin? One of the best places on the body, not, let's leave the head out and the mouth out. Where's the best place? Palms and soles of feet. That's the best place to determine somebody's true color, okay? If they're cyanotic, if they're jaundiced, things like that, okay? We're going to check for skin turgor. So we know we come here, pinch the skin up, and watch it rebound back, okay? We're going to then inspect those nails and fingers. And then while we're here, what else are we going to check?
Capillary refill.
Okay. What am I going to say out loud other than, okay, I'm just looking at our nails and fingers and checking capillary refill? What are we doing? We're checking for symmetry. We're checking for thickening, discoloration, clubbing. There you go, clubbing. We're looking for all these things that could be wrong, that could indicate, I'm sitting here holding my hand, could indicate a problem with that patient's body. Okay, fingers tell us a lot. Okay, and so we're going to say that we're looking for these things. We're going to check for capillary refill, which is we're pressing down that nail, letting go, and looking for it to return within 2 to 3 seconds. I want to hear you say that, okay? We're looking for that color shape, whether the nails are firm, smooth, rounded, convex, and then those capillary refill. We're looking for that blanching and then return back to color in 2 to 3 seconds, okay? We're still at the hands, okay? We're still going down the systematic body system. okay, or the systematic way. So I'm gonna check grip strength. I want you to squeeze both of my fingers here as hard as you can. Keep squeezing. We're a little, okay, and you can release. Always use 2 fingers. That doesn't hurt. Okay, you give them 4, it's gonna hurt. You give them 2, they just about can't hurt you. Okay, so 2 fingers. Now, what am I gonna say out loud that I'm checking for? Well, I'm checking grip strength, but what am I looking for? For it to be symmetry, equal on both sides. Good grip strength, a 5 out of 5. Don't go that deep. A 5 out of 5 is as strong as they can be, okay? Grip strength. Now we're gonna we've come here, now we get to these hands, now we're gonna go to abdomen, okay? So the abdomen, and when we're assessing the body in general, that auscultation gets a little out of line, it gets out of sorts, right? So we always inspect first when we're assessing. So we're inspecting this abdomen, but how does my patient need to be whenever I'm inspecting their abdomen? Do they need to be sitting up like this?
No.
Supine. Need to be supine. So I'm going to be inspecting the abdomen. I'm going to be inspecting for color, for vascularization, because anytime somebody has like varicose veins or venous, never mind, let me go. But you're looking for any kind of scarring abnormalities, venous, could be some hepatic problems. If you see some veins on the abdomen that are kind of popping up almost like varicose veins. We're looking at that umbilicus. Is it center? Inspecting. We're just looking, okay? Then we're going to go to auscultate next, correct? Before we palpate. Will that give you a big ding if you go to palpate before you auscultate? It will, okay? There's a certain order you're supposed to do this in. Where am I going to start at? Right lower, listening for vowel sounds. I want to listen in for 5 to 20 a minute. We're going to start here. We're going to go a systematic 4-quadrant area where we're listening. Our patient, you need to say it out loud, my patient's going to be supine, okay? Then where are we going to go as far as our auscultating those 4 areas? After we've done that, what else are we going to be asking for? And really, it's best, you can do this all together. It's best as long as you inspect before you listen and before you palpate, okay? But I'm getting ahead of myself, y'all. GI is the only time you're going to go to palpate, okay? In the regular head-to-toe physical assessment, right here, it's inspect and listen, and you're done, okay? There's other things to do, but we're not going to be palpating this. We're not going that detailed in this GI assessment, okay? But what we are going to do is ask them as we're inspecting what? Ask them if they've had any what?
Bowel movement.
Bowel movement, their last bowel movement, the consistency of it,
The color.
the amount, the color, diarrhea, okay? Or was it loose? What else are we going to ask them as far as GI?
About the urine.
Okay, we're going to keep it real simple, head to toe.
The urine.
Nausea, vomiting, it's on your checkoff sheet. If they're having any nausea, vomiting, anorexia, diarrhea, or constipation. Okay, remember we're on a general head to toe physical assessment, okay? So after that, the finger squeeze, we'll go to abdomen, inspecting, asking questions, and auscultation, okay? And then we're also, while we're there, we're going to auscultate for an abdominal bruit. What side of the stethoscope do we listen to when we're listening?
The bell.
The bell of the stethoscope that I don't have. The bell of the stethoscope, but when we're listening to regular, just long and hard, where are we going to listen? Okay, so we turn our bell of the stethoscope, and we're going to be listening. We're actually going to put these in our ears. We're going to be listening from just below the xiphoid process for abdominal bruit. What am I listening for? What am I going to hear if I hear a whoosh? And we're going to listen all the way down from xiphoid to just below umbilicus, okay? And when we're assessing abdomen, we're looking for that from that xiphoid to that symphysis pubis, okay? That's where we're assessing that area, okay? So that completes the abdominal assessment, which is a little bit more in detail. A cardiac, we're just listening to the PMI, okay? So abdominal gets a little more detailed in the general assessment. then we are at the stomach. Now that we've gone from our stomach, where are we going to go down to now? Our legs, okay? And we're going to assess for edema. Where do we assess for edema? Do I just push anywhere that I want to push?
No.
Over the shin. Why? Less fat, and there's a bony prominence to push against that really highlights that edema, if there's edema, okay? So you go to the shin, and you press down. Do we just push and let go?
Mm-mm.
You press and you hold it, because what you're wanting to do is displace those tissues. That fluid that's accumulated in those tissues, you kind of hold some pressure, you give it a few seconds, up to, several seconds, and you let go, and then we just feel for that impression or that indentation for edema, okay? And edema is 1+ to 2, 3, 4+, okay? 1+ being minimal, 4+ being pretty extensive edema, okay? So we're still in that head to toe. We've assessed the extremities for edema, and then we're going to get to where that. What are we down here looking for?
Dorsalis pedis pulse.
Okay. On this general assessment, it says for you to assess for that dorsalis pedis, the one on top of the foot. Okay. You mind just sliding that shoe off real quick for me? Because we want you to. I want to see that you know where to go. Because I've seen people go down here. Is that the right place?
Mm-mm. It's about middle of the foot.
Normally, we're going to be about right here, and there it is, beautiful as it can be. I can see it. Okay. You're not going to find mine. So right there, good as it can be. Perfect pulsation. This is the area where we're going to find it. I want to know that you know where to go to find it, okay? Then again, back to that skin on our assessment. But it's that general again. Anterior, posterior side, we're assessing that skin. When you say it, I'm going to look at anterior, posterior side, both surfaces for lesions, moles, scars, the erythema. And I'm also going to assess all those bony prominence, because my patient's been laying in the bed for about 3 days. And I'm going to assess all these bony prominences for any kind of redness. Where else is a bony prominence? Cocci, heels. We're going to be assessing all and verbalize elbows, coccyx, heels for any kind of erythema or skin breakdown. Okay, that's your general assessment. Everybody is going to do that. Okay, then before you get started, you will have read your patient, your simulated patient that has the cardiac problem or the respiratory problem, and then you're going to fall into a focused physical assessment, unless you choose to do it while you're doing your regular assessment, okay? And now I'm going to go through those steps as far as each one individually. Respiratory, so our patient's got a lung problem, so we're going to focus more on the respiratory. So I'm going to tell my instructor I'm checking off with, I'm going to ask my patient's respiratory history, including, are you a smoker? So do you have any kind of respiratory history that you're aware of? Such as, and you're a smoker, okay? Such as, do you have bronchitis or asthma, COPD? Don't be scared to throw those words out. That just tells us you know what you're talking about, okay? I'm assessing for their history. Are they a smoker? Have you had any recent cough? Okay. Can you describe, okay, at least you're giving me something to talk about now. Can you describe that cough to me?
It's productive.
See, she already knows what to say. So you'd ask, are you having a productive cough? What color is it?
Yellow.
Yellow. Okay, we're getting scared now, right? So there's all those details you go into, but if your fellow student says they're coughing, you got to go into some detail with them, okay? So then we're going to assess that breathing. The use of accessory muscles. What's the use of accessory muscles? Are using that abdomen to abdominal breathe instead of just that diaphragm to breathe. Okay, so are they using accessory muscles? Say that. I'm checking to see if they're using any kind of accessory muscle use. I'm assessing their breathing pattern. What's a breathing pattern? It's the depth, the rate, whether they're using those accessory muscles, whether it's shallow breathing, deep breathing. That's assessing that true full assessment on that respiratory status. Okay, so all these things we're doing, we're inspecting. Okay, remember that's that first step. We're inspecting. You go through those inspecting steps. That's the way we want to see you do it. Inspect. Then we're going to go into palpating. and then you palpate front and back, pressing gently with fingertips, and you'll just say, I'll go over the entire chest wall, palpating the chest. That's the entire front chest wall while I have my patient set up, and I'm going to palpate the back of the posterior side of the chest wall, okay? Chest wall goes down to where? All the way down to here, okay? So this is not just chest wall, front, back. We're down to here and down to here, okay? Where those ribs are sitting over, protecting those lungs, okay? So we're palpating, we're checking for symmetry. Any, say this out loud, I want to hear it. I'm checking for symmetry, deformities, crepitus, any of those things that could possibly be going on with those patients, any kind of bony defect, lumps, bumps. And then we're going to, again, listen to those lung sounds, but we've already listened to the front 12 sounds. Where do we need to go to?
Side and back.
We're going to do the back. I'm going to be listening directly on the skin. Again, we start at the very top up here, just above the scapula. Okay, here. Where's my next spot? Why do we go straight across? We want to compare. Okay, we want to compare. Then straight down, ladder form, over, down, over, down. Do we want to be listening over here, over that bony scapula? No. You can even have the patient, if you're needing to really, you can have them pull their shoulders forward or rotate those scapula out of the way, like she's really doing, to listen to these lung sounds, okay? So we're at 12 areas too. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, okay? Zigzagging down, okay? So we're listening to those lung sounds. Verbalize what you're listening for. I'm listening for those abnormal, adventitious lung sounds, okay? Any questions on respiratory? Okay. Cardiac, we're gonna again go into that detail. Do you have any kind of cardiac history? Okay. We could go on in to say, do you have a cardiac, I wanna ask my patient, do they have a cardiac history? Do they on any blood pressure medications? Do they have any vascular disease? Do they have any shortness of breath or fatigue? Chest pain, difficulty breathing? Are they a smoker? What's their exercise like? What's their diet intake? That's a cardiac history, okay? We'd like to hear you say all those things, not just saying, well, that's a cardiac history, okay? Go into detail. Those are all questions about a cardiac history. Then we're gonna palpate those carotid arteries. Important, we only palpate one side at a time. Hopefully everybody knows that by now. So what we do is you can have that patient just lean over a little bit, and where are we palpating? Right here. I'm not back here. I'm not up here. I'm right here. Everybody must make sure you understand and know where to palpate that carotid artery. It's pretty simple because you feel it on yourself and you know where to palpate, okay? So we're going to palpate this side and then this side, okay? Can I use my thumb? No. Always use these first 2 or 3 fingers, okay? So we're going to palpate that carotid artery. Then I'm going to auscultate for that carotid possible bruit, okay? Using the what? Bell of my stethoscope. You want to tell your patients, if you ever listen to this, please stop breathing for just a second, because it will hurt your ears, and you ask them not to talk, because if they talk, it will hurt your ears, okay? So to listen, we're just going to place the bell of the stethoscope over. Of course, we'll have this in our ears. Listen to the bell of the stethoscope over that carotid artery. Turn to the side, bell of the stethoscope over that carotid artery, okay? We're also going to assess for that jugular vein distension, okay? What is jugular vein distension? Extra fluid. Could be a heart disease, a lot of pressure in that right atrium. As that heart beats, there's so much pressure, it's pushing back up into that neck, okay, into that venous system. Or it could be venous overload, okay? So how are we going to do this? We want our patient what? Supine, with the head of the bed at what? What's our head of the bed need to be at? What's it at right now? 45 degrees, okay? Head of the bed is elevated at 45. We're gonna get her to turn her head to the side. And what am I looking for? I'm observing right here for a pulsation going up the neck, okay? And if patients have it, turn this way, and I'm gonna look on this side. Normally, if they have it in one place, they're gonna have it the other, but the most likely is gonna be on that right side, that same side as that atrium, or where the vascular system's bringing that blood back up to the heart. So we're gonna be looking for that pulsation in their neck, okay? This is the way to do it. You need to do it that way. Your fellow student does not need to be supine. They need to be like flat. They need to be on their back, 45-degree angle, turn to the side, and tell us what you're looking for, okay? Looking for that pulsation, okay? And then we're going to finish up our cardiac. We've worked at our head. Now we're going to go and feel for that dorsalis pedis, or that tibial pulse. So we felt for the dorsalis pedis on our general assessment. Now we're going to be feeling for that, the one that's on the posterior side of the tibia back here, okay? So where's that at? Everybody know where your little ankle bone is, the malleolus, that bony prominence sticking out? You're going to feel right behind it on the back side of it, okay? Now, I'm not feeling with my thumb, I'm feeling with these first two fingers. I'm just using that thumb as a rest, okay? But we're going to be checking for that posterior tibial pulse, okay? And then, unfortunately, I'm fine with you going ahead and listening to the heart before you go down there if you just want to stay in that head to toe. We're going to auscultate those 5 precordial landmarks. We'll put our stethoscope in. We're going to be listening on the skin, not over the clothes. Where's this first landmark at? What intercostal space? Second intercostal space. Here. Normally that's going to be that rib that protrudes the most on your chest. Okay, that first one's kind of hidden. Second one kind of protrudes out a little bit on your chest. Are we going to be over here? What are we going to be against? The what border? Sternal border. Okay, we got our sternum up front. It's the flat bone. We're going to be just to the side of it. You can feel these little grooves. If you need to feel on somebody, come feel on somebody. You can feel these, okay, on a lot of people. Then sometimes a breast tissue or somebody, if somebody's like, kind of like got osteoporosis, they're going to be harder to feel, okay? So we're going to be listening here. Second intercostal space, sternal border. Which specific valve are we listening to when we listen right here? Yes. Almost got tripped up. Aortic, okay? A, B, C, A, first one, A. Aortic, okay? What is going to be over here? Pulmonic. Second intercostal space, at the sternal border, okay? The next one is called a Erb's point, and I'm going to come to me, okay? Next is called a Erb's point, sternal border. It's in second pulmonic sound, okay? That's going to be your next area. All right, then we're going to stay on that sternal border, okay? Down on the fourth intercostal space. What am I listening to here? Okay, tricuspid valve. And then I'm going to come back over to that PMI. Fifth intercostal space, midclavicular line. What am I listening to over here? I want y'all to think about that. Make sure my notes are right.
Apex.
Apex, apical, which is also that mitral valve. Okay, mitral's over here, tricuspid's that fourth intercostal, and then the fifth is going to again be that mitral valve. Okay, that's your apex, point of maximum impulse. Okay, you just draw your little chart to remind yourself. That's going to be your 5 precordial landmarks that you're listening to the cardiac sounds. Okay, so then we're going to go to a neurological assessment. That we're going to get that orientation to person, place, time, and situation. Okay, so we're going to assess that by asking again, can you tell me your name, You know where you're at. Get them to tell you, okay, the time and the situation. Is that the same way I just did it earlier, okay? Are they alert? So what if they didn't have a response to you? How are you going to determine their orientation, or if they're alert in any way? You increase that stimuli. You go from, hi, hey, to touching, to get to wound up being a sternal rub, if you have to. Okay, so that's going to be that neurological assessment. And then we're going to assess, we're going to go into mood and affect. I'm going to assess my patient, or you can just say, my patient today, she seems happy, she's smiling, or she's crying, she's upset. That's that mood affect. Are they pleasant? Are they apprehensive, angry? And then you go on into that recent or remote memory. They've already told you why they're here. You can say that out loud. I know a patient's recent history is intact because they just told me why they're here, their name and date of birth. What was your first, have you ever had a dog before?
Yes.
How old were you when you got that dog, that first dog?
9.
Do you remember its name?
Remington.
There's your distant memory, okay? So that's a way that you can determine if that's intact. We're also going to assess gait, where you'd have your fellow student get up and walk across the room, and they can get up, they can walk across the room, or you say, I'm going to assess their gait. What am I looking for? Steadiness, a normal arm swing, and then they're having good balance, okay? So you're going to assess that gait walking across. And then there's the Romberg test we're going to expect you to do, okay? That's where the patient's standing still, feet straight down, arms by side, they close their eyes, 20 seconds. And what you're doing, or we're going to be with them right there, we're going to be right there with them. Have your fellow students stand, hands by side, feet down, eyes closed for 20 seconds, and you're going to stand there with your arms on each side of your fellow student, assessing that they are not going to lose their balance. Do you have to go a full 20 seconds? Just tell us. I'm going to have them do this for a full 20 seconds, okay? And then you can keep moving on. And then we're going to assess that cranial nerve 3, 4, and 6. That's the 6 cardinal gazes, okay? You all remember how to do that? So what we'll do is say, I want to check my patient's cranial nerves 3, 4, and 6. And we're going to start here. We're going to be about 14 inches, can y'all see okay, from our patient's face. We're going to start at the center, and then we're going to go up and back down, out, and then down. So we're going here. My points are here, here, and here. And then the same thing on the other side. And you move slowly. What am I looking for to ensure that my patient's neurological status is intact? What am I looking for? Any kind of nystagmus, like the eyes bouncing back and forth, okay? Or them not being able to follow my finger, okay? So that's what you're looking for. You need to tell us what you're looking for, okay? I'm going to assess the cranial nerves. I'm looking to ensure that my patient doesn't have nystagmus, or their eyes don't jump or move back and forth. We're looking for that smooth movement of that eye. Then getting into further a focused GI assessment, we get into the oral cavity. That's where you're going to need your pen light to be able to look into your patient's oral cavity. You'd have them to open their mouth. What am I looking for? I'm looking for moist mucous membranes, pink moist mucous membranes. I'm looking for any kind of lesions, white patches, or any fillings that may be lost. Do they have dentures? Do they have full dentition? They're normal, their regular teeth. And then also their nutritional status. How's your appetite been lately? Okay. And we also, her appetite's been good, and nutritional status would be indicating her body size. Your fellow students, or your patient's body size, okay? Indicating that. We're getting again back into that last bowel movement. When you ask them, I want to ask, when was your last bowel movement? Yesterday, and they'll answer you, okay? We again, just like we did previously, we're going to be inspecting that abdomen. Remember, for any kind of pulsations, lesions, scars. Is our abdomen rounded? Is it flat? Is it distended? Is it soft? And this is where we'll get into the more of the palpation. So earlier we inspected, we auscultated. Remember, our patient's going to be supine. And then when you go to palpate, you want your patient supine, but you want their knees flexed a little bit to get a little pressure off that abdomen so you can truly palpate that abdomen, okay? And what we'll do is just a light palpation, starting in that right quadrant and working around that abdomen, okay? Just you would lightly palpate it. Now that's going to be after we do what though? We got to do what first? Got it? What do we have to do first? Auscultate. And it's, with this gastrointestinal assessment, it's the same as before. As we already did, you're going to auscultate for those quadrants. You're going to be listening for the bruit, just like I demonstrated earlier, and then that light palpation, okay? Also, when you're inspecting, you're looking for symmetry for the abdomen to be the same on both sides, okay? Any questions? Thoughts? Okay. I did a lot of talking, okay? Y'all gonna be doing some talking and a lot of doing on your checkoff, okay? Does that make sense? We want to see you actually doing these things, okay? And talking us through. All right.